On behalf of the Training Center, the Center for STI Prevention at Maryland DHMH, and the STD HIV Prevention Training Center at Johns Hopkins University, I'd like to welcome you to the third annual STD Awareness Month webinar on sexual and reproductive health care. What about the young male? Before we begin our presentations, I'd like to invite all of our online participants to visit our website to view our available online and face-to-face trainings. In addition to the trainings available on our website, our upcoming face-to-face trainings include Applied Public Health Ethics, Community Assessment, Logic Models, and next month's Grand Rounds on reducing asthma disparities in children. For those watching online, we invite you to email questions to the presenter at any time during this broadcast by clicking on the link on your screen, and ask that you please sign in so that we can report more accurately to our federal funder. We also ask that our audience in the building put your phone on vibrate so that we won't interrupt our speaker. At this point, I'll turn the floor over to our partner and co-sponsor, Barbara Conrad, Chief of the Center for Sexually Transmitted Infection Prevention at DHMH.
Good afternoon. I'm so glad that you're able to join us here today. We are pleased to present the third annual STD Awareness Month webinar, a collaborative project between the Center for Sexually Transmitted Infection Prevention at Maryland Department of Health and Mental Hygiene, the Mid-Atlantic Public Health Training Center at the Johns Hopkins Bloomberg School of Public Health, and the STD HIV Prevention Training Center at Johns Hopkins. In honor of this April's National STD Awareness Month, we are fortunate to have as our presenter Dr. Arik Marcell, an assistant professor at the Johns Hopkins University School of Medicine in the Department of Pediatrics and at the Johns Hopkins Bloomberg School of Public Health in the Department of Population, Family, and Reproductive Health. Dr. Marcell is also the Director of Adolescent Services and the Title X program at the Harriet Lane Clinic at Johns Hopkins. He is a board-certified pediatrician and adolescent medicine specialist. Dr. Marcell's research focuses on male, adolescent, and young adult health, including sexual and reproductive health, and on access to care from both the patient and provider perspectives. He conducts interdisciplinary research integrating behavioral science, health services research, and public health practice. Together with the Male Training Center for Family Planning and Reproductive Health, the Centers for Disease Control, and the Office of Family Planning, he is leading the Men's Health Technical Panel to inform updates to the nation's Title X clinical guidelines. This year's webinar focuses on young males' sexual and reproductive health care needs within the overall framework of sexual health. The webinar will conclude with a live question and answer session, so please be sure to think of questions and submit them as we go along. And now, Dr. Marcell.
Thank you. It's a real pleasure to be here today. Before I review my objectives for the talk, I just wanted to share that we have nothing to disclose, and there are a few slides here in the beginning that we'll repeat at the end that reviews the continuing education credits that will be offered through the CDC. And at the end here, this slide will be repeated at the end that describes both the course number as well as where to go online for credit. So my objectives for today's talk is that by the end of the session, you will be able to describe young males' sexual and reproductive health care needs, as well as current STI screening and treatment recommendations, in addition to thinking about frameworks to engage this population in sexual reproductive health care. You may ask, why should we be addressing or focusing on young men's sexual reproductive health? Young men have sexual reproductive health needs in their own right. We need to be addressing both sides of the partner equation, as well as the needs of all men, and the needs of clinicians regarding knowledge and interactions with males on sexual reproductive health related topics. One major need for young men in this country is related to sexually transmitted infections. About 19 million new STIs are estimated each year by the CDC. In 2010 alone, 1.3 million cases of chlamydia are estimated, 300,000 cases of gonorrhea, as well as rates of syphilis are rising among Black men over the past 5 years. 90% of these STIs are due to chlamydia, trichomonas, and human papillomavirus, and about half of these STIs are diagnosed in teenagers and young adults, as you'll see in these next slides. Specifically for chlamydia, rates among men in U.S. by age and race ethnicity, here you can see that the highest rates are among men aged 20 to 24, and next highest among male teenagers, with rates highest among Black men. For gonorrhea rates, the rates are similar as to the pattern for chlamydia, with rates highest among men aged 20 to 24, and next among teens, and then next among 20 to 29-year-olds, and also highest among Black men. Syphilis rates follow a similar pattern, with rates highest among the 20 to 24 age range, but then next highest between the ages of 25 to 44, and also highest among Black men, and men who have sex with men, and that's not shown on this slide. But specifically for Maryland, let's just review what these look like. And as you can see here, although the ages are flipped from the prior photos, you can see that for both chlamydia and gonorrhea, the highest ages for chlamydia and gonorrhea are the same as for the nation. This is similar for syphilis cases in Maryland. And this slide here for trends from 2007 to 2011 in Maryland by gender and sexual behavior really show the increasing rates of syphilis among men who have sex with men over this time period. So it's important to understand that sexual behavior is a normal part of development. And over time, we're seeing fewer never married male teens reporting ever having had vaginal sex from the mid-90s to the present. However, still, about half of male teens are reporting ever having had vaginal sex. And these decreases are not being observed for all racial ethnic groups. They're steepest for African Americans, but less so for whites, and we've really seen no change in reports of ever having had vaginal sex for Hispanics. Among males who are not reporting vaginal sex, about 13% are reporting either oral sex or mutual masturbation behaviors. So really, about almost 2/3 of US male teens are reporting any type of sexual behavior. We're also seeing trends of increasing condom use among male adolescents since the 1970s. Increases in condom use have both reports from first sex and last sex. So at first sex, about 80% of boys are reporting increases of condom use with variation by race ethnicity. The numbers here are shifted, but the numbers in blue to the right of this slide represent the most recent data from the National Survey of Family Growth. My arrow is not working so properly. Nope. So we are seeing increase of reports among whites and condom use at first sex over the time frame in the last 15 years, but really no change in increased reports among African Americans and some increase in reports among Hispanics over the last 10 years. When it comes to consistency in condom use during the past 4 weeks, we've really seen no changes in this in the last 10 years. And at first sex, only 16% of male teenagers are reporting dual contraception use. That's the use of a hormone method plus by their partner and a condom. And we're still seeing some substantial proportions of males, even though on the lower end, that are reporting no method at either first sex or at last sex. So 15% of male teens are reporting no method by themselves or a partner at their first sex experience and their last sex with their partner. It's important to consider male teen sexual behavior in the context of their other risk behaviors. So for example, about a quarter of adolescent males are reporting using alcohol and drugs before their last sex experience. And about 6% of these young men are engaging in HIV sex risk behaviors that are listed on this slide in the parentheses. Also compared to female adolescents, males are reporting earlier age of sexual onset as well as more partners. These are both factors associated with increased risk of STDs. When it comes to thinking about sexual reproductive health outcomes, we're actually seeing mixed trends for male adolescents over time. Although we're seeing overall decreases in unplanned pregnancy and potential decreases in teen fatherhood, rates of chlamydia have been increasing over the past 2 decades, mainly related to improvements in our diagnostic screening. Increases in syphilis, as I described, especially among men who have sex with men. And we really have, even though related to incurable STIs, herpes, there's a decrease arrow there. We have poor data for tracking herpes and human papillomavirus among male adolescents. So it's really unclear what these trends have been doing over time. And finally, ideally, young people are supposed to be developing a healthy sexuality, yet we are really focused on just measuring problems among young people, particularly STDs, and we really don't have ways to measure healthy sexual development over the same time period. This is important because the WHO, the World Health Organization, defines sexual reproductive health as a state of physical, mental, and social well-being, and not merely the absence of disease, dysfunction, or infirmity in all matters relating to the reproductive system, its functions, and its processes. The WHO further elaborates that sexual reproductive health requires a positive and respectful approach to sexuality and sexual relationships, that to attain and maintain sexual health, sexual rights of all persons must be respected, protected, and fulfilled, that sexual experiences should be pleasurable and safe and free of coercion, discrimination, and violence, and that men, and that's my emphasis, along with women, should have the right to be informed as well as have access to family planning methods as well as healthcare services. So how might this definition translate into the kinds of outcomes we can address in a clinical setting with this population, with young male adolescents? So the goals for male sexual reproductive health care, beyond just controlling and preventing STIs and HIV, should be thought about to include unintended pregnancy, reproductive health cancers, promoting sexual health and development, healthy intimate relationships and responsible behavior, as well as fatherhood, reducing sexual dysfunction or problems with sex and infertility, and increasing lifespan, survival, including quality of life, as well as access to clinical services, and that patients are satisfied with these services. Additional needs, particularly for the male teen, relates to puberty and non-STI related issues. Related to puberty, we need to understand sexual maturity ratings, what's normal, abnormal based on a physical exam, as well as when to appropriately refer, secondary to lack of progression. And non-STI related issues, more common issues for young people include varicoceles, understanding how to identify testicular torsion and refer immediately for appropriate salvage, hypospadias, gynecomastia. So next I would like to move on and review sexual reproductive health care for male adolescents. We know that few teen males report receiving sexual reproductive health care services, and according to both provider and patient reports, few males are assessed for sexual health, counseled on STIs and HIV in pregnancy, assessed or counseled on contraception, as well as condoms. One concern is whether or not the sexually active male teen are just not coming in, and this is what's being reflected in the information that I presented in the prior slide. So to answer this question, we looked at the National Study of Adolescent Health, also called the AdHealth Survey, that followed the same sample of youth over a 1.5-year period. In both of these surveys, they asked youth whether they're sexually active in both waves of these surveys, whether they're sexually active and whether they had a healthcare visit in the last year. So for these analyses, we created 4 groups of sexual behavior status from baseline to follow-up, and I'm hoping I can get my arrow to work. So whether or not they are sexually active at both time points, whether they initiated sex from baseline to follow-up, whether they abstained from sex from baseline to follow-up, and whether they were not sexually active at both time points. The x-axis is the baseline and then the follow-up. And the y-axis is actually these teenagers' reports on whether or not they received a health service in the last year. And you can see that among females, visits increased among all sexual behavior categories, included females who initiated sex over the time frame. But among males, visits did not increase, especially among males who initiated sex from baseline to follow-up. But what you can see is that the majority, on average about 65% of both males and females, they are reporting 2 visits in the last year. So these are opportunities or potential missed opportunities if services aren't delivered. But what's also important to know is what's not reflected on the slide, that 1/5 of male adolescents who were sexually active at baseline and follow-up are not reporting any visit at baseline or follow-up. So this is a population that is being missed. So if the majority of sexually active males are having health visits, perhaps after major adolescent health recommendations came out in the mid-90s, we would see an improvement in teens' receipt of some of these types of services related to sexual reproductive health. And for this study, we used the most recent available data from the National Survey of Adolescent Males and the National Survey of Family Growth, 2 comparable surveys over time. The first one was assessed in 1995, the next one in 2002. In both of these surveys, males were asked if they talked about STIs or HIV with a doctor or nurse in the past 12 months. And as you can see here in the white line, that among all males, only about 1 in 5 are reporting receiving this type of service in the last year. And then when we start to look at males who have greater sexual reproductive health, who are engaged in sexual reproductive health risk, the proportion increases slightly, but still only 1 in 3 boys are receiving or reporting that they were counseled about STIs or HIV by a healthcare provider in the last year. And when we tested for differences across these 2 cohorts and time, we saw that there are no improvements over time, regardless of sexual risk category. We've looked at the most recent data released from the NSFG over the 2006 to 2010 time period, and we've seen similar findings, that we are still static in the young men's report in services received. So we find that teens are experiencing many barriers for getting and receiving sexual reproductive health care, and these barriers are occurring at multiple levels. Healthcare providers are not comfortable in general assessing for sexual health, but clinical services are not necessarily well designed to serve male adolescents' sexual reproductive health needs. In addition, we really lack public health messaging that sexually active males should be receiving seeking services, as well as receiving services. And I'm going to talk about the lack of guidelines in a little bit. As well, male teenagers lack access to care, especially older boys, and we may see some improvements with the Affordability Care Act, but we'll have to track to see if that actually comes to fruition. A framework that I'd like to think about for sexual reproductive health care seeking for young men pulls from the social ecological model. You can see here that care seeking is influenced by 4 general domains: at the personal level, at the social level, structural, and cultural levels. So let me just walk you through with some examples. At the individual level, there are interpersonal factors such as knowledge about care services, attitudes that doctors may not be trustworthy, or insurance or income issues that may influence care seeking. At the social level, males rely on parents, teachers, peers, and partners for health information. For example, a mother's appointment making may help their sons access services, but if she stops, does he know what to do? At the structural level, factors such as male clinic friendliness may come into play. And at the cultural level, factors such as gender role and masculinity beliefs and social role norms may actually be particularly important. And I want to talk about masculinity and how this is defined and how this may influence care seeking next. So masculine beliefs are actually socially constructed ideals for the male role that's rooted in the ecology of culture. And it's typically measured as masculinity ideology, that the belief in the importance that men adhere to culturally defined standards for male behavior. And I was interested to examine the influences of male adolescents' healthcare use and whether male beliefs have a role in this. And to answer this question, we looked at the National Survey of Adolescent Males that followed the same sample of youth over a 2.5-year period. For these analyses, we examined the relationship between predisposing factors, including an individual's masculinity ideology score, enabling factors listed here, and as well as need factors with the report of a healthcare use at a future time frame. In this study, masculinity ideology was measured using the male role attitude scale, and participants were instructed to respond on a scale that the extent to which they agree or disagree with each of the following statements. So just to walk you through briefly the findings, in this sample, about 12% of the male adolescents reported holding more traditional masculine beliefs. About 2/3 of the sample held neutral beliefs, and about 1/5 of the sample less traditional masculine beliefs. Overall, we found that after controlling for important predisposing, enabling, and need factors, that males with more traditional masculine beliefs were significantly less likely than males with neutral beliefs to report a physical exam in the last year. We also found that other factors that were protective for healthcare use included health insurance status, having health insurance, self-report of general health needs, and males who talked with both parents about sex. But risk factors for healthcare use in addition to masculine beliefs included being older in age and living in the south of the US. But one of the assumptions in this model is that males' healthcare decision-making is on their own. And as I described to you in a couple of slides earlier, the framework, the social ecological framework, this might not always be the case. So just some takeaway points for these three studies that I reviewed with you briefly is that the majority of sexually active males are interfacing with the healthcare system. Clinicians will not know if these young men are sexually active if we are not taking a sexual health assessment of them. In addition, the delivery of sexual reproductive healthcare services to males is poor. Clinicians need to start following guidance related to this area for our young male adolescents. In addition, multiple factors are influencing male sexual reproductive healthcare use. Clinicians need to be aware about these factors, as well as educate males and their parents about sexual reproductive healthcare services. And then finally, multiple factors influence providers' delivery of sexual reproductive healthcare services to males. And I'm not going to have enough time today to really go through these factors in great detail. But we need to break down these barriers that address both time, reimbursement, other factors at the clinical setting level to improve service delivery. So next, I would like to describe current STI screening and treatment recommendations for males. And I want to do this in the context for us to start thinking about how to be bundling sexual reproductive health care services to deliver to this population when we see them. One of the major challenges for delivering these types of services is that really no one organization makes recommendations for adolescent males, let alone for males across the lifespan when it comes to sexual reproductive health. With the Affordability Care Act, the main organizations who will inform what kinds of services are covered rely on Bright Futures through the American Academy of Pediatrics. Bright Futures makes recommendations through the age of 21, but when it comes to the sexual reproductive health domain, it really appears that recommendations will only be through the age of 17, and that then USPSTF, the U.S. Preventive Services Task Force, recommendations will kick in for adults 18 and older. And these recommendations, the services that will be covered will only be for recommendations that are graded A or B. Other and both organizations defer to the Advisory Committee on Immunization Practice, the ACIP, as it relates to vaccinations across the ages. And for the purposes of this talk today, I'm going to highlight some recommendations by the CDC. There are a number of other organizations that inform topics within the sexual reproductive health domain as it relates to the male across the lifespan. I won't have time really to go through the details of what these organizations state. If you have questions about that, I'd be happy to take them at the end. Before we go into the brief summary, I wanted just to provide a framework of what services are clinical preventive services. In the next set of slides, I'm going to summarize screening, routine screening related to history components, physical examination components, particular laboratories, routine counseling, and recommendations related to vaccines. And I'm going to focus on the Bright Futures and the USPSTF. And I'm going to focus on Bright Futures recommendations as they pertain to males under the age of 18, but also highlight our young adult male age range, since the majority of STIs really live in this age range. So there are 3 STI-related services that fall under screening and counseling. Bright Futures recommends screening for puberty, sexuality, and sexual behavior, and both organizations recommend providing STI/HIV counseling among sexually active adolescents and at-risk adults. The USPSTF, by default, recommends screening for sexual behavior, since you need to know who's sexually active in order to counsel those who are sexually active. And just to review with you how these organizations make the recommendations, right now the Bright Futures recommendations for males are based on expert panel review, represented by the E here and in the key. And then, like I mentioned, the USPSTF grade each of their recommendations. So a grade B on this slide represents moderate net benefit that they recommended. A grade I is that there's insufficient evidence to recommend for or against, and thus it's a no. So you can see here that there's relative consistency in the recommendations across both guidelines as it relates to screening, history, and routine counseling. To highlight just what the STI/HIV counseling would look like, the USPSTF recommendation is for moderate to high-intensity behavioral counseling to prevent STIs among all sexually active adolescents and at-risk adults. And one method to do this, and the citation is listed on the slide, that was part of the review in the recommendation, would be 2 separate 20-minute clinical sessions 1 week apart. During the first session, one would assess patients for personal risk, barriers to risk reduction, and identify a small risk reduction step that's accomplishable within 1 week. During the second session, 1 week later, to review with the client the prior week's behavioral change successes and barriers, provide support for changes made, identify barriers and facilitators to change, and to develop a long-term plan for risk reduction with the person. And the study that tested this model found that participants in intervention clinics receiving structured behavioral counseling reported significantly higher condom use and fewer new STIs than participants in the control group. And that males and females actually benefited equally from counseling interventions, and that this intervention was more effective among adolescents than older participants. 2 services fall under the physical exam component, and as you can see here, they're the sexual maturity rating and genital exam, and these are only described by the Bright Futures for male teenagers. The USPSTF does not make any recommendations as it pertains to related STI physical exam components. And then for laboratory tests and vaccines, there are a number of them. So I'm just going to walk you through this slide, which may look busy, but you'll have a good understanding as we complete it. Bright Futures recommends routine screening for chlamydia and gonorrhea among male teenagers who are sexually active. For the USPSTF, they actually state there's insufficient evidence to support for or against screening any aged male. Although the CDC actually convened a consultation regarding male chlamydia screening, these data have not yet been included in any update by the USPSTF. This consultation occurred in 2006, and the actual update that is reflected by the USPSTF specifically didn't include any data pertaining to screening men. It only included the benefit of screening men to women on women's health. So we still are left with an I statement by the USPSTF. Regarding other STDs, there's consistency in what is or is not recommended across both organizations. For hepatitis B, C, and herpes simplex, you can see here that Bright Futures doesn't make any mention, and based on the review, these would represent no recommendations, where D stands for no benefit, and so they would recommend against. For syphilis and HIV, there's consistency by both organizations to screen among at-risk teens and adults. And then for vaccinations, there's consistency across both organizations to do so by ACIP recommendations, and I'll review those in a moment. So you can see here that there are some discrepancies, particularly as it relates to chlamydia and gonorrhea screening by both of these organizations. I wanted to just highlight what the findings were for the male consultation by the CDC as it relates to chlamydia. And what they summarized and made recommendations is to screen at-risk males, particularly in settings, and that when males are under the age of 25, except for one caveat, in adolescent clinics, including high schools, upon entry to correctional facilities, and STI clinics through the National Job Training Program. The caveat by age is in the military, where there's an upper age range cutoff under the age of 30. And then to consider screening in communities where there's high prevalence. For example, screening men under the age of 25 in the kinds of settings that they might be seen, such as the emergency room. In addition, screening for men who have sex with men, as well as be sure to rescreen a male who has been tested positive for chlamydia 3 months later for reinfection. And the citation for that and the website where you can pull it down yourself is listed on the slide. Regarding the vaccine recommendations, the ACIP recently released an update to the HPV vaccine for males in actual full support to recommend vaccinating all males ages 11 to 21 with a caveat for permissive vaccination among not at-risk males ages 22 to 26, but vaccinating at-risk males who are at higher risk, including males who are having sex with men or who are immunocompromised through the age of 26. So you can start as early as age 9, but standard start time is probably ages 11 to 12 with catch-up among non-previously vaccinated age males or those who have not completed the vaccine series. Hepatitis B vaccine is recommended for all persons aged under the age of 19 and all at-risk adults. And hepatitis A vaccine is recommended for all persons at risk. The definitions of both of those are in the slide. And it's not routinely recommended to screen an individual, whether if you don't know their hepatitis B status, to see if they've are immune to the vaccine, rather than just start the series if you're not able to get documentation about the vaccination. So before moving on to describing components of the actual visit with a male, I would want to help you continue to think about ways in which to bundle services. And one of my motivating factors to do so has been the lack of guidance that we have related to male sexual reproductive health by organizations, by professional organizations in this country. And I was interested here to examine whether clinical experts in male health perceive, what kinds of needs they perceive that male teenagers have in this domain, and whether they have consensus on the types of services that they would recommend delivering for this population. For this study, I interviewed 17 clinical experts in male health. They were inclusive of physicians as well as nurse practitioners from varying specialties who had, on average, 30 years of clinical experience, who work in public and private settings, in settings across the nation. And overall, experts generated a common list of 19 topics listed here on the slide. The majority of the clinicians, you can see, separately listed generated 7 topics. Needs related to hormonal contraception, mental health and substance abuse, male anatomy and function, sexual basics, responsibilities and relationships, sexual health and communication, condom basics. And you can see here that these experts are kind of in line with the WHO's definition of a broader framework for sexual reproductive health for young men, capturing topics that are broader than just focusing on STIs and HIV. Of the top 14 topics, 13 of them actually are clinically relevant services that we can deliver in the clinical setting. And the only one that isn't, dealing with cultural expectations of what it means to be a man, may not be a standard reimbursable clinical service, but these are the kinds of concepts that we can incorporate into our counseling strategies with our young males, depending on the kinds of issues that they're dealing with. So for the top 13 related services, we then ask the experts to tell us which of them they would deliver during a routine visit with a young man. So here you can see that of the top 13 services, 10 services are being recommended by the majority of experts. And this is the case when there's no limit in time. I mean, this is part of a 40-minute routine type of visit. But we did ask them also if they were limited, if their routine visit was limited to 15 minutes, how would their recommendations change? And you can see here that the majority of experts are still agreeing to deliver 6 of these 13 services, including pubertal growth and development, genital abnormalities, not including STIs and HIV, STI-HIV risk reduction, including testing and treatment as appropriate, male-focused pregnancy prevention methods, substance abuse and mental health, and physical and sexual abuse. But when we asked the experts to tell us which of these services they would deliver as part of more of an acute type visit, a different visit type, and here the scenario was for an ear infection, this is when the experts were not in agreement. And only half of them recommended STI-HIV risk reduction, including testing and treatment, and screening for substance abuse and mental health. So what I find is that, this study shows that experts can agree on services to deliver to male adolescents as part of routine visits, as well as the number of services that they're recommending vary based on the allotted time for the visit. But most importantly, I find that this study shows that the use of an expert review, although it may be on the lower end of the evidence ladder, can be useful in a context when evidence in published literature is lacking and can't inform recommendations at the same level when studies have not been done yet, and thus can inform the kind of work that we should be delivering to males as part of sexual reproductive health care. I've been working with the Male Training Center on family planning and reproductive health, and since 2010, leading updates related to men's health for the nation's Title X clinical guidelines in collaboration with the Office of Family Planning, the CDC, and experts in the field. And the goal for this document and guidance is to describe a scope as well as minimum standards of sexual reproductive health care for males across the lifespan using an evidence-informed approach. And here we're hoping to rely on evidence-based recommendations whenever possible, but to also examine professional organizations for recommendations across the lifespan, including the CDC, the American Urological Association, and engage experts in the field in order to inform the process and help us address the gaps. Our white paper should be out by the summertime, and we are hoping that the Title X guideline updates should be released before the end of the year. So let's move on and I'm sorry. The last thing I wanted to say about the guidance is that beyond the type of material that I presented related to STI services from the organizations that we reviewed, our goal is to address other sexual reproductive health related services listed on this slide in the guidance as well. So I want to move on and walk through the components of the male sexual reproductive health visit and briefly review general principles for taking a history and conducting an exam and reviewing laboratory specimens needed for diagnostic purposes. So general principles for taking a history for a male are really no different than that for a female. We should be sensitive and non-judgmental, use active listening, open-ended questions, provide a comfortable environment. I personally recommend performing the history with the clothes on, and depending on the male's age, it may be important to discuss confidentiality and exceptions, since confidentiality is not unconditional. Reporting requirements include reporting when there's harm to self or others, sexual and physical abuse in minors, as well as positive STI results in persons of any age. And finally, take a comprehensive sexual history. So I like using acronyms, and I find it's very helpful for me to really remember the core components of the comprehensive sexual history. So here, S stands for sexual experience and sexual abuse, as well as history of sexually transmitted infections. O for the onset of sex for that individual. U for unprotected sex, but also to remind me to ask about knowledge about hormones, hormone use by one's partner, knowledge about emergency contraception. N for the number of partners. D for drugs while having sex, or that could influence appropriate hormonal use or condom use. D also for dysfunction, to review problems with any sexual function. And D for pregnancy history and fatherhood history. So I want to move on to the actual components of the exam. Reasons to perform a sexual reproductive health exam in a male include addressing normal and abnormal findings. And this is focused on the genital part of the exam. For example, abnormal issues may include the varicocele, the hydrocele, meatal abnormalities such as hypospadias, signs of testicular trauma or atrophy, but also normal issues that one should reassure, like penile pearly papules or sebaceous cysts. Address issues for young men who are not circumcised that include phimosis or hygiene, and then also to ensure that a male is where he's at in his pubertal development related to both hair growth and testicle size. But there's other parts of the body for us to be thinking about when it comes to a complete sexual reproductive health exam. This includes examining the breast and looking for gynecomastia that may be abnormal, that may be normal or represent actually an underlying pathological issue. Address common and easily treatable issues of the skin, such as acne, tinea cruis or jock itch, folliculitis. Discuss maintaining bone health, screening for STIs from all exposed sites, and addressing high blood pressure and issues with obesity that may be reflective of underlying cardiovascular disease that could also impact sexual health and function. Screening and the actual exam itself is an opportunity to just talk about sexual reproductive health in general and help a young person understand what his sexual reproductive health needs might be. And although examining the testicle to actually screen for testicular cancer and to teach the male to perform a self-exam to screen for testicular cancer is no longer recommended by the USPSTF, you can see that there's many other reasons to perform a genital exam, and as well as a broader sexual reproductive health exam for a young man. For the examination itself, ask the young male to change into a gown and use universal precautions and standard techniques to handle clean and contaminated exam components as outlined on this slide. And start from the top down. Examine the mouth for signs of lesions, discoloration, mucus patches. Infections that can occur here include chlamydia and gonorrhea, syphilis, herpes, Candida that causes thrush. Palpate the lymph node chain, including sublingual, cervical, epitrochlear, axillary nodes. We'll talk about inguinal nodes in a second. Inspect. Having a patient actually in a gown can facilitate a full exam of the skin, including the face, but also the trunk and the legs and the back, hands, palms, and forearms, soles of the feet if syphilis is suspected. Here you want to be looking for lesions such as lesions and rashes, discoloration. For the actual genital exam itself, familiarize yourself with male anatomy if you aren't already. The phallus, contents of the scrotum, including the testicle, the epididymis, the spermatocord and the vessels, and the location to detect a varicocele. Internal contents including the urethra, vas deferens, and the seminal vesicles located internally, as well as the prostate. Other important landmarks include the meatus here, the corona at the base of the glans, the frenulum on the ventral surface of the penis. Also understand the role of the tunica vaginalis and the anatomy, and how it only covers just half of the scrotal circumference, and its role in testicular torsion, if that's actually open all the way around the testicle, also called the Bell-Clapper abnormality, but also its role in hydrocele if fluid collects in there, as well as hernia. Sometimes a male may be actually embarrassed to have a genital exam, and just like we do with our female patients, we need to be using standard language to explain the importance of this part of the exam, as detailed on this slide. And I also recommend having the patient stand for the major part of the genital exam, to use a stool to sit comfortably, use a source of light, to really help medicalize the exam for both the patient as well as you as the provider. Some additional principles, as we do with our female patients, is to briefly review with the patient what to expect during the exam, before the exam, and then as we are walking through the exam. I recommend touching a non-genital part of the area of the body first, use eye contact, talk to your patient during the exam, let them know that findings are abnormal, or if there's a normal finding, what it's about. Watch for signs of fainting as he's standing, but try to avoid lengthy discussions with the patient in a compromising position while he's in a gown. Remember to remove the exam light off a genital area as soon as possible because it could be hot. And to remember to examine painful areas last. I approach my exam in a consistent manner to ensure that I don't forget any component of my exam. I start in the inguinal area and examine lymph nodes first, and here I'm looking for fluctuance, swelling, or tenderness. I next inspect the pubic hair for crabs, lice, or nits. I make a notation of hair stage for sexual maturity rating. Also, I check the skin around the genital area for any lesions, warts, or skin conditions. During this part of the exam, I might actually sweep the penis to the side and hold it against the inner thigh if it's in my way, to make it easier to actually examine the scrotal sac. And this also makes it easier if a patient is embarrassed as part of this exam, and or gets an erection during the exam. And if the latter occurs, I always reassure to the patient immediately that this is normal, that the exam will be over shortly. I try to use verbal distraction by moving on to the next part of my exam and what I'm going to be doing next. If it's not easy actually to do this as part of the exam, after he's dressed, be sure to address it before the visit is over to reassure that it is normal and that it's really no big deal. Next, I palpate the scrotal contents, gently compressing the testes and epididymis between my thumb and first two fingers, noting here for tenderness, shape, mass, swelling, or nodules. Here, I size the testicle on each size, and then I identify the spermatocord with vas deferens and note again for any tenderness, swelling, or masses. Finally, for the penis, I inspect the skin and the shaft glands for any ulcers, raised lesions, or signs of inflammation. And if the male is uncircumcised, I ask him to retract his foreskin so that I can fully examine under the foreskin and the glands. And I gently compress the glands between my thumb and index finger to open the urethral meatus, inspecting the meatus for any signs of stenosis, lesions, or malposition of the urethral opening. If there's no discharge visible, I'll strip from the base to the glands, the shaft of the penis, and look for any signs of discharge. There's a question mark in front of performing hernia exam. We really don't have any evidence that routine screening for hernia is effective or not. The recommendation is based on symptoms, and I'll leave that up to you. Before we conclude the exam components, I just wanted to review briefly male sexual maturity rating. The majority, if not all of the patients by clinicians who are listening to this are probably finished with pubertal development, but I wanted to review with you what those typical findings would be. So if it's off, you know when to refer. For hair, the standard stage 4 findings are that the inguinal triangle is completely full, but there's no extension of hair. That's the sign of stage 5 hair development, where it extends onto the thighs and up the umbilicus, up towards the umbilicus. For testicle size, the standard volume for stage 4 is 10 to 15 cc's per testicle, or 4 to 4.5 centimeters in diameter, with a penis length of about 11 to 17 centimeters when flaccid and no shrinkage. Volume for testes size for stage 5 is 20 to 25 cc's and greater than 4.5 centimeters in diameter. And it's not uncommon that the left testes might hang slightly lower than the right. Yes. And if you have testes size that are smaller than what I described, or hair findings that represent an earlier stage of development, these are reasons that you should be concerned and refer your patient for further workup. One tool that you might find helpful if you don't have currently in your practice is an orchidometer. This is a method to actually measure and document testicular volumes. And finally, based on a male sexual experience, you will determine whether or not you need to do an anal inspection. Here, I recommend having the patient lie on a table on his side and examine the perianal areas and the intergluteal cleft for lesions, rashes, discharge, warts, fissures, and then exteriorly the anus for ulcers, discharge, and any other lesions. Sorry. And finally, the need to use a chaperone is dictated by state and practice setting guidance. The American Academy of Pediatrics states that a provider should be sensitive to one's patient's feelings about an exam, and provider judgment and discretion must be paramount in evaluating the need to actually use a chaperone. For a male who's presenting with STI symptoms, the appropriate specimen should be collected. If a male is having discharge, you want to be collecting specimens for gonorrhea and chlamydia. If the discharge is coming from the penis, using the first void specimen of a urine sample, not of the day, just the first part of any urine sample, using nucleic acid amplification tests, also called NATs. If gram stain is available, you can do this as well. If the discharge is coming from the anus or the pharynx, here we can use endocervical swabs in order to collect specimens for the young man using a NAT approach. If NATs are not available for gonorrhea, the ideal specimen that's probably still available for us is a culture, and again, gram stain, and the plan would be to give presumptive treatment. For chlamydia, the option is really to just give presumptive treatment, since our access to enzyme immunoassays, EIAs, are really not as readily available as they were about a decade ago. If you're concerned about trichomonas, either because of persistent penile discharge or despite treatment for gonorrhea and chlamydia, or a partner who's tested positive for trich, in your clinic, if you have available microscopy, you can spin down a urine and look for trichomonads using a saline wet mount, or if you have access to testing with a trick pouch, or also the newly available NAT test, you can use this as well. For ulcers in any location, you should be testing for herpes and syphilis. For herpes, the PCR, the polymerase chain reaction, and the culture are preferred. However, viral culture is less sensitive and loses sensitivity as the lesion is resolving. If you're suspecting syphilis, you may actually want to use the newly available rapid test as opposed to just a screening test with a RPR or VDRL. If you're concerned about prodromal symptoms for HIV, we have 2 tests available: rapid HIV testing, either through an oral swab method or a finger stick with results in 20 minutes, or a standard serum HIV test. And finally, I just wanted to review some updates with the most recent STD treatment guidelines as it pertains to treating men for both urethritis and epididymitis. For gonorrhea, urethritis, there's an update. The dose of ceftriaxone has increased to 250 milligrams intramuscularly as a one-time shot, with a change and treatment with 2 modalities instead of just 1. So now we are adding azithromycin, 1 gram orally as a one-time dose. Quinolones are no longer recommended because of issues with resistance. And with increasing resistance against cefixime, I think in the last week, our first case of cefixime resistance to gonorrhea was noted. So this really should not be a first-line option anymore in the treatment for gonorrhea for men or women. For chlamydia, azithromycin is still our standard method in the similar dose as I just described, the 1 gram oral one-time dose. And just the framework to treating a simple infection such as urethritis is exactly the same as our method that we treat women for cervicitis. So it helps to simplify our regimen approach. And epididymitis is very similar. Treating epididymitis is very similar to our approach that we use for treating PID in women. The outpatient regimen for epididymitis is still 250 milligrams of ceftriaxone in an intramuscular shot, one-time dose, and doxycycline, 100 milligrams orally twice daily. And instead of 14 days for PID, it's a 10-day recommendation for males. The same reasons we would admit for PID, you might consider admitting for epididymitis if he's unable to take oral medicines, his overall appearance, or inability to follow up. And consideration to add anaerobic coverage is only for PID and not epididymitis. As it pertains to other STIs, there have been no changes in CDC recommendations for syphilis, herpes, and trichomonas. And finally, for partners of patients treated for chlamydia and gonorrhea, the primary recommended approach by the CDC is to bring in your own partner, BYOP, to notify the sex partner, to see a provider, to get tested and get treated appropriately. Now, if the partner can't come in or won't come in, there might be some optional approaches, and this is really based on what's available by law in your state. This includes expedited partner therapy. This is not available for us here in Maryland. Or perhaps use of an accelerated partner therapy approach. It was just published in the UK study using a hotline. So these are things that we might consider, that we make a hotline available for the partners of our patients so they can call and find out where they can go to get tested and treated. For specific partner management strategies, refer to the most recent STD treatment guidelines, and the website is listed on the bottom of this slide. Finally, reporting requirements are the law, and STIs, including syphilis, chlamydia, and gonorrhea, are required to be reported by both laboratories and healthcare providers. And the rationale on our end is to ensure that patients have received their appropriate treatment, and this enables state and local health departments to better monitor disease trends as well. Be sure that all demographic information on the forms are completed. For the state of Maryland, our forms are on these next two slides on the website where you can pull them down, are listed on the slides, and these have just been recently updated in January of this year. So in summary, I hope that you're now able to describe that male teens have substantial sexual reproductive health needs in their own right. To improve negative sexual reproductive health outcomes among this population, we need to address both sides of the partner equation and consider male social ecology, including involving parents and communities, schools, as well as consider our role as healthcare providers in addressing the needs of all males, not only the needs of heterosexual males. But in order to do this, we also need more data in order to appropriately inform evidence-based clinical guidelines for young men's sexual reproductive health. In the interim, Bright Futures provides guidance on STI-related services to deliver to males, and as it relates to the ACA, the Affordability Care Act, through the age of 17, although their recommendations are through the age of 21. But we're missing important supporting documentation to inform guidance on males ages 18 and older. Please also remember that STIs are very common among males, and to assess for sexual behavior, to perform a comprehensive male sexual reproductive health exam, and to routinely screen for STIs using an evidence-based recommendations. And finally, for patients presenting with symptoms, perform the appropriate diagnostic tests and use evidence-based STD treatment guidelines by the CDC. The last slide here are some resources for clinicians to use for males through the Male Training Center, the National Network of STD HIV Prevention Training Centers, as well as a couple of resources from the CDC itself, including what I learned is new apps for the treatment guidelines on iPad, iPhone, and iTouch. Thank you so much, and I'm happy to take any questions.
See first if there are questions here in the audience. We do have a microphone for any questions here in the audience. Okay, we have a couple.
Very nice talk, Dr. Marcell. Can you give us some information about fathers' roles? I saw in one of your models you had maternal education as one of the factors that you're looking at in terms of how their male health outcomes in seeking sexual health services. There have been some studies looking at the role of women in adult males' lives, but what's the role of fathers as their sons are developing and helping them have healthy health-seeking behaviors?
That's a great question. And as far as I am aware, there are no studies that look at that association, the role of fathers as it relates to care seeking for male teenagers. There are studies that look at the role of parents and educating their teens about sex, and those studies engage whoever's available, sometimes the mom, sometimes the dad, sometimes both mom and the dad. But those studies around sexual reproductive health don't necessarily take it to the next step and help us understand males' use of services and access to care.
And how about the role of boys growing up in mother-headed single-family homes as compared to those growing up in homes with two fathers? There's some work by Ralph D. Clemente that suggests that boys are looking for places to get resources about how they should engage in relationships. And so I'm just wondering about in terms of who they live with.
Yeah, I think the work has really been in the domain of sexual reproductive health as opposed to taking it to sexual reproductive health care. We have a better understanding of the role of both parents involved in the lives of their children in timing of sexual onset and use of condoms, but not in the care-seeking domain. So, those are great questions for hopefully future work to inform how we can do a better job in engaging young men in services.
You painted a wonderful picture of, not only sort of the research component, but also the healthcare aspect and how the Bright Futures and U.S. Preventive Task Force is making recommendations. How do you see that the Affordable Care Act is going to actually impact male health, given that there's some disparity between both the Bright Futures recommendations and the U.S. Preventive Task Force?
So even if you go to the ACA website, I actually even have concerns in what services will be covered for boys as it pertains to Bright Futures. Related to STI screening, it doesn't tell. It tells you for adults, but it doesn't articulate. I'm sorry, the light is in my face in order to actually see you well. It doesn't articulate well the services that male teens will have access, that will be covered. The other thing to note, if you're not aware, the ACA guidance is for really any new insurance plan that's created as part of these markets. So the services covered will be for these new insurance, as part of these new insurance plans. So it's still unclear whether pre-existing insurance plans will come up to speed and take up those services as well. Hopefully, to be competitive, they will, but that may be another issue.
Any other questions here in the audience? Okay, we'll keep it open for the audience, but we'll move to some questions that we've received by email during the webinar. Here's our first one from email. Have you reviewed any studies that speak to connections between sexual disease in young males and portrayals of young males in movies, television, and other social media?
That's a great question. I'm not aware of any studies that look at specifically exposure to media portrayal and young men's increased risk behavior. But I think that the general literature around media and behavior in the realm of sexual health does show that. So I don't know if they've teased out gender specific issues as it relates to young men's risk-taking.
Okay, and for our next question, can you say something about safe rectal recipient sex and how to prevent rectal and colon problems for both men and women?
That seems like it would be, an extensive talk that we should think about for next year. I'm not as familiar with, our recommendations for screening are to screen, and I didn't include the slides here, are to screen, all sites where there's exposure. But I'm not sure if I understand when they're talking about safe sex, like how to have safe sex, or recommendations for that.
I think that's what the question is.
Right. So, I think the recommendation is to use condoms as the preferred method to decrease transmission related to any potential STD and HIV.
Okay, thank you. Next question from the email. Can you recommend resources for people working with young boys regarding rites of passage or puberty?
So there are a number of studies that have looked at that. Most of that literature is is outside of this country, is not domestic. One, I think, excellent resource is out of Brazil, called Instituto Pro Mundo, and the program that's called Program H, or Program Hombre, that I would recommend them to look at, that address exactly that.
Do you know if that's available on the web?
It is available on the web.
What was that name again, please?
Instituto Pro Mundo. I can maybe write it onto the slide when we finish for you to view, it's easily searchable, and they have materials on their website, and you can request CDs of their materials as well as some videos that they've developed for boys as well as other populations that they've developed interventions on.
Great, thank you. Here's another one from email. What is the reason that in an exam, the provider should ask the uncircumcised male to retract the foreskin himself? Is it for his comfort?
I find it's more so for his comfort. If it's part of your practice that you've been doing it, that's fine. I find it more comforting on his part that he has some control in that part of the exam, and then I'm not doing something that he's either not expecting or might be uncomfortable. I mean, if he has a minor phimosis, it actually could hurt.
Okay, thank you. Here's another one. Has there been any consideration given to developing paternal and child health programs similar to maternal and child health programs?
That's a great question. I think what's missing from MCH is actually the P or the F, the parent, the paternal or the father, and I think we need to be really thinking about how to help our policymakers understand the needs of men as well as boys and men.
Okay, and next from email, can you comment on the value of notifying partners when there is a positive test result for an STI? How can health departments help with this?
So if you haven't actually ever had a discussion with your health department, I would encourage you to pick up the phone and ask them that directly. Just learn what are the available resources. Every jurisdiction is completely different in how funding and resources are available. It may be that the funding and resources are really only available for partner tracing for syphilis. But if you have a very hard to reach individual and their partner for gonorrhea and chlamydia, and you've been trying, for weeks or months to get them in, and you might know where they live, it might be in that circumstance that your local health department can help you actually trace that individual. So I think just pick up the phone, have the conversation, build that relationship, and hopefully with time we'll have more resources to partner trace for more than just syphilis and or gonorrhea, depending on your jurisdiction.
Yes, and I think also that sometimes local health departments can be a source for testing and treatment.
Right.
If an individual that has been notified through your client or through your office doesn't have insurance.
Absolutely.
Or needs a place,
Absolutely.
another place to go. Thank you. We have another question here. What are the best ways for schools and communities to act as resources for young men? How can educators partner with providers to fill gaps in male health care?
And the first part of that question was schools and communities, is that correct?
Yes.
I think if schools actually have health services as part of their school environment, either if it's run by the health department or run by the school system, these are easily accessible settings that males need to know, that they're available, that they're accessible to them, for us to think about ways to socially market the kinds of services that are most effective for us to be delivering in these settings. If such a school-based health clinic doesn't exist, for schools to learn about either local public health department, STD clinics, or other types of family planning or public health clinics that, if in the situation a young person is needing to seek confidential services, these are the kinds of settings that typically understand and provide low cost or free services to young men or young women related to confidential care. partner also with parents and community providers so that the population of young men, again, understand what is sexual reproductive health care and how we as providers, clinicians, can address their sexual reproductive health needs. And finally, within the classroom setting, incorporate that messaging as part of the standard sexual health curriculum, which is typically lacking or just focused on access to care for contraception for girls, but not necessarily what are comparable services that males should be accessing.
Yes, I especially appreciate that emphasis for comprehensive sex ed. It is something that we need to do a lot of work around.
Right.
Any other questions here in the audience?
Do you mind repeating the question so that the webinar can hear you?
Sorry about that.
Sure.
Yeah. I think you had mentioned the fact that clinical healthcare providers, there's kind of a lack of knowledge or a lack of comfort in addressing some of these medical issues or sexual reproductive health issues with young males. And why does that, what accounts for that phenomenon?
So, there's multiple levels to this phenomena. It starts in clinical training during medical school and beyond, where we really don't have the kinds of curricula built around male sexual reproductive health as we do around women's health. It extends to the lack of clinical guidance by professional organizations. I'm trying to address some of those gaps. The American Academy of Pediatrics just released in December its first clinical statement on male sexual reproductive health care for the teenager. And then a statement through the Society for Adolescent Medicine focusing on reasons to do a genital exam despite the USPSTF recommendation against screening for testicular cancer. We don't want clinicians to see that and say, oh, I don't need to do anything anymore. There's many reasons to do a genital exam beyond screening for testicular cancer. So I think, it's raising awareness. Guidelines alone don't change clinical practice. It's changing kind of social norms of what's been lacking for male reproductive health with the emphasis on services for women, going back to the MCH model. We've got organizations like, ACOG that focus on services for women and for female teenagers, but we've been behind on doing similar approaches for young males.
Okay, another question from email. What is the best way to address the risk associated with HPV number 16 and 18 since these don't show up on the male but are very dangerous for the female partners?
So, I think the importance of consistent condom use, that was one of the pieces that we really haven't, even though at first and last sex we're seeing increased reports, this consistency of lack of condom use and really no change of increasing reports of consistent condom use hasn't been increasing over time. And I'm hopeful for us to learn better methods to detect those types of infections in men. I know there are some studies in the field that are trying to do so through DNA testing from urine samples. They're very hard to isolate from urine because of interactions with the urine. But hopefully we'll have better collection techniques so that there may be ways to monitor that in males as we do in females.
Thank you.
A lot of your research focused on what doctors have said they could provide in terms of timing for the adolescent male. Have there been any studies on what adolescent males say they want and kind of a comparison between what doctors think they should get and what males feel they should?
So that's a great question, and we just completed a 2-city study looking at young men ages 15 to 35 from clinical settings, asking them, in what areas do they have sexual reproductive health concerns, and on what topics are they interested that the doctor should bring it up, or they'd rather bring it up, or that may be too personal. What's interesting is that the majority of the topics, which really mirror the topics that I reviewed as part of that clinician study that I presented, for the majority of those topics, regardless of age, these young men want the provider to bring it up. And even among those who have an issue, they still want the provider to bring it up. They don't necessarily want to bring it up themselves. So it's really on us to bring these topics up as part of our work with young men in clinical settings. We could use screening, written screening tools or computer-based, modules that young men can fill out before a clinic visit that generates, what are male's concerns or what are topics that he might be dealing with that day. Clearly, time is a factor as part of a clinical visit, and we have to prioritize why he came in and maybe some of what our needs are to address for him. But that kind of approach can help us prioritize, well, what are some of these other domains that might raise higher on the priority list. If we don't ask that if he's ever made a partner pregnant and that he's an expectant father, like a patient of mine just a couple of weeks ago, I wouldn't know that in 3 weeks his partner is going to deliver. I mean, that's a major potential, well, it's a happy event in his life, but it's also a major stress in his life because he was dealing with a number of financial issues and completion of school issues that allowed us to address that as part of that clinical visit. Otherwise, that would have gone unchecked.
Recommendations would you give to your patients if they received either a HPV or a herpes diagnosis in terms of informing their partners, whether that be calling up past partners, telling their current partners, or informing partners in the future?
That's a great question. I mean, I think our standard approach has really been focused on more of these curable STDs, and getting them in for diagnosis, but also most specifically treatment. The guidance isn't as clear of what to do, for HPV or herpes. I mean, I think it's still a really important discussion to bring both individuals in, to be able to describe to them, not only what is the disease, the implications of that diagnosis, but also implications for prevention. If both if there's a discordancy in the diagnosis. And I think the literature is probably a little bit more substantial related to HIV and disclosure as opposed to HPV and herpes.
We have another question from email. Are there any recommendations regarding screening for violence and sexual violence among males, either as potential victims or as perpetrators?
The answer to that is yes. The Bright Futures clearly describes that. There's a organization, and the name is escaping me, and I think it's listed on the slide of other organizations in the slide set. And the IOM report on women's clinical services, which I really didn't have a chance to talk about in detail today, talks about it for routinely screening women and the importance to address, men as part of intimate partner violence as well. And we talk about it in our white paper, as well as the guidance that will be coming out in the updates for Title X. So, you can look forward to seeing that hopefully before the end of this year.
Great. And we have just a few more minutes here, another 5 minutes. Any last questions here in the audience? And I have just one last question from email. Can you repeat the website?
Yeah, I was going to just do that.
The Rites of Passage resource that began with Hombre. And that will be added on the slides when they are posted, but I think it's a week before. I think things will be posted on the web, 7 to 10 days for things to be posted. Okay, so live. live from Baltimore.
And learn about that program.
Okay, great. Project H. Well, thank you very much, Dr. Marcell. This has been very, very informative, and I think that you can see by the range of questions that we had today that covered A to Z that this is certainly a topic that we all need to learn more about, and we're so glad that you're doing work in this area and helping to get this out to more people. So thank you very much.
Thank you. It's been a pleasure. And a final reminder that this webinar will be archived within several weeks on the Mid-Atlantic Public Health Training Center site for 2 years. And then these are the slides at the end of your presentation handout that lists the website where you can go to for continuing education from the CDC, as well as the course number. And don't forget to complete an online evaluation depending on how you viewed this webinar, either live, offsite, or archived.
Thank you very much. This will be the end of our webinar, and I just wanted to clarify that the archive will be up within 2 weeks, usually a little bit sooner, and we can also try to post a link to some of the resources, particularly that people were asking about. We hope you'll all join us again for our next Public Health Practice Grand Rounds on May 16th. Thank you.